Okay, well, let's go start with the first case, please.
Okay, a 72-year-old man with a distant history of smoking is being followed for carotid artery stenosis. He denies any history of stroke or TIA. He is on an aspirin and high-dose statin. Carotid artery duplex showed more than 70% stenosis of his left internal carotid artery with peak systolic velocity of 350 and end diastolic velocity of 145. He is able to walk a mile without shortness of breath. He has no cardiac history. He has had no previous surgeries or radiation to his neck.
All right, so what we have, so 70% stenosis and asymptomatic, correct?
Yes.
They said he denies any history. Okay, so the question, you're in the clinic, they refer patient to you. The cardiac ultrasound shows 70% stenosis. So most of you be the question, what's your next step, right? So what's your next step? What do you do?
I will complete my history and I will do full vascular and neurological examination.
That's good. You see, I like about you, but you stop. Don't give too much information. That's good. Physical examination, look at negative for any abnormality. So physical exam, everything's normal. So what do you do next?
I would like to do a CTA of the head and neck.
Good answer. The only thing here is that you're planning for treatment, correct?
Yes.
Because if not planning for treatment, but you don't need to do a CAT scan, you know?
Yeah.
So it's a tough situations because I don't know how the examiner back in his mind, you know, because some vascular said no, 70% asymptomatic, I just watch it, you know. If you go with the guidelines, American guideline, they said no, 70% you have to be treated. But you have to look for, if you go to the European Society, they said you have to look for high risk, you know, signs before you treat. So, so again, I mean, it's just for practical, I mean, practical in your real life. If you're not planning, if you decide, no, I'm not going to treat this patient, we don't need a CAT scan. But if you
Yes.
said, no, I'm going to treat him, then have a CT scan, okay?
Yes.
So let's talk about asymptomatic. What is the guideline tell us about asymptomatic? When we have to fix it?
Yeah, if the stenosis is more than 70%, if the patient is
Okay.
having high risk feature on the duplex ultrasound, like unstable black,
And
if there is contralateral occlusion of the internal carotid artery.
Correct. Okay. Or hypoechoic, you know, like a plaque you see behind, or hemorrhage behind the plaque. So you said unstable black, yes.
Yeah, if there is high
or contralateral occlusion, then you high risk. But what the most important to decide? Let me go back to questions. Say what if you go back to questions? Wait, we're not getting back. They said he's no cardiac history and no previous history already to the neck. He walked without any shortness of breath. Why did they give you this information? Why he just stopped here? Why he said why give is not able to, he able to walk without shortness of breath and no cardiac history? Why he give you these two information?
That's mean his life expectancy is more than 3 years, and he's in good cardiac condition. He will tolerate carotid endarterectomy.
Okay. What if he has a cardiac history but he's stable, but he cannot walk for a long distance, but he's still life expectancy more than 3 years? He just, you know, he has angina before, has coronary artery disease, but no acute coronary syndrome now, and he's not very active. Do you still do surgery or not?
I will counsel him about the benefit, risk and benefit of surgery and stenting, and I will do cardiac stress test.
So what number are you looking for? What is the magic number you're looking for?
If his ejection fraction is more than...
No. What I'm saying, we're going to decide I'm going to do him or I'm not going to do him. Is there any special things? what the guidelines said. They said you can do him, but they put a conditional. It's that stroke and death should be less than 3%, correct?
Yes.
Okay, this is the most important. So if he's high risk for surgery, then he loses benefit from cardiac endarterectomy for asymptomatic patient. So to do asymptomatic, your stroke rate and death should be less than 3%, and life expectancy more than 3 years. There's two things. So what does that mean? Patient he just graduated from fellowship, he should not do asymptomatic carotid stenosis because your stroke rate is high, more than 2%. Because you're just doing carotid, you don't have much experience. So really, any patient, any physician, he should do at least 50 carotid endarterectomy symptomatic before he consider asymptomatic. Because if your stroke and death rate more than 3%, you lose this benefit. So benefit is very, very narrow. The reason why, again, they don't advise somebody just graduate to go and do asymptomatic carotid stenosis, okay? So your death and stroke should be less than 3% and life expectancy more than 3 to 5. So any patient with high risk, like if patient has a coronary syndrome, acute coronary syndrome, and we came with this picture, I will not do CT scan. I just say his high risk for surgery, his stroke risk and death more than 3%, then I just go with the medical management. But in this scenario, they gave you a patient is active, walk a mile without shortness, no history of cardiac history. So I should expecting that his death and stroke less than 3%, then I may offer him, and there's no radiation to the neck, then I may offer him surgery. Okay?
Okay.
So it's very important to know that.
Yes.
All right, so let's go. Sorry. Okay, so negative. So what do you do? Code the stroke rate first. Okay, so what would you code this patient's stroke rate at 1 year with ophthalmic and carotid? And that, so how much carotidectomy would decrease your risk of stroke per year for
Yeah,
asymptomatic
according to
patient?
the ACAS trial,
Mm-hmm.
it decreased the risk from 11 to 6%.
So it's half. It's correct.
Yes, almost
So it's
half to
half.
1%. Yes.
Correct. So usually, if asymptomatic, your risk of 1 year is about 2% per year if asymptomatic. So if you do surgery, you decrease it by half, so it'll be like 1%. Okay.
Yes.
This is the way how it. So carotid endarterectomy would decrease your incidence of is 1%. So you see the incidence is low. It's the reason why you have to good reason to do a surgery. You just decrease it from 2% to 1%. So patients high risk for surgery, old guys, and does not worth this benefit. But young guy, active, then this 1% per year is going to live like 10 years, so have almost 10%. So it worth it. But it's going to live only 2 years, so 2% is not benefit. The reason why they said at least 3 years, so at least you can feel this difference in the surgery. Okay.
Yes.
All right. So the patient status that his father had a stroke and he has seen how devastating that can be. He would like to pursue surgery. Is there any testing you would want prior to surgery? What usually we do?
I will do CT scan. I will do ECG and echo, and
Okay.
complete blood count and coagulation profile.
Okay, that's good. So what type of monitor do you want to use and why? This is a very important question. I'm sure you're going to get this question in the exam. Whatever you use, you have to find why, okay? Because there's no definite answer for this one. You may answer me, I answer different, you answer differently, everyone's going to answer differently. But you have to have a kind of neuromonitoring during the procedures, and you have to find why I need to do it. So tell him what really you want, you do it. Don't tell him what he want to hear, So what usually you do, whatever you're planning to do, give it to him and let him know that you do that one.
I will do cerebral oximetry and EEG.
Okay. Do you have at your hospital EEG? He's going to ask you.
I have it, yes.
Okay. So I was going to ask you, what do you see in EEG? It's going to make you difference. It's the reason you see this way, he wants to know if you're really using it or not, Is any special changes? You see it?
Yes, if there is appearance of delta wave, if there
Okay.
is any uh, if there is any decrease in the alpha or beta wave by more than 50%, that's an indicator of
Okay.
shunting.
So during the procedure, you have a technician with you or the neurologist with you in the ward?
Neurologist.
Neurologist. Okay. What if you see them both sides bilateral? What do you do?
Bilateral.
Yeah, you see delta wave bilateral decrease on both sides, right and left.
I will compare it to
You
the
should,
cerebral oximetry.
okay, both sides
If I
went
have,
down. Both sides went down.
I will I will look for the vitals of the patient. Maybe
No,
he's
this is from
hypotensive.
no. No, this is from the anesthesia. If you see both sides, it's nothing to do with your side. Because if you see both sides, this is nothing to do. This is from the anesthesia. Maybe they give him too much, sedation. Maybe suppress the waveforms. So when you see in both sides, don't worry about it. This is anesthesia. Talk to anesthesia or just forget about it. You have to sit on one side to make a difference. So if you see in both sides, that means from the anesthesia. All right. So you do monitoring and you trans TCO2. Okay, there's an acceptable. Is any other way? Let's put it this way. Now I like to ask you, is there any other ways to,
Yes,
monitor the brain?
stump pressure measurement.
What is abnormal when you think, when you're going to interfere?
If less than 40 mercury, then I will put shunt.
Okay, what else?
Transcranial Doppler.
Okay, what else?
I can do under local anesthesia and
Yeah,
monitor the
yeah,
patient.
look,
Clinically.
yeah, local anesthesia is a good way. All right. So what the benefit and pitfall to using EEG? We said about benefit. What the pitfall? It has a lot of false positives, right?
Yes.
So the reason why if you use TCO2 or with it, always I like to use really two measurements because none of them really accurate 100%. Because if we have one is accurate 100%, then everyone should use it. But because everyone use differently, they still use that none of them is accurate 100%. What I usually like to do two at least, like as I said, like transcutaneous plus neuro monitoring, neuro monitoring plus stump pressure plus TCO2. So always try to use two at least to get a right accurate measurement. Okay, let's take us through the surgery. Can go through quickly, but let's go through the main step.
Okay, after positioning and general anesthesia, hyperextension of the neck, skin incision anterior to the sternocleidomastoid muscle, dissection of the platysma flap, mobilization of the sternocleidomastoid muscle laterally, exposure of the carotid sheath and mobilization of the jugular vein laterally, exposure of the common carotid artery and control it with the vessel loop, exposure of the internal and external carotid artery, giving
Before you
5,000
exposure, before you expose, what are you going to ligate?
facial vein.
Okay. When you dissect the common carotid artery, what do you have to pay attention to?
I don't want to move the artery a lot. Careful movement of the artery. I don't want to do any.
Correct, not
Yes.
maneuver, but something important there, you have to look for it and try not to damage it.
Hypoglossal nerve and vagus nerve.
Yeah, first Vegas, we didn't get hypoglossal still high. So when you talk about common carotid artery, when you open the sheet, you have to tell him, I pay attention to the vagus nerve, not to injury. The reason when you do common carotid, you have to circumferentially dissect, not only anterior and put a clamp. Because if you just dissect anterior and put a clamp, you can damage the vagus. So you have to
Yes.
dissect the common carotid artery circumferential. And then when you're dissecting around the external internal carotid artery, what you have to look for, or what you have to tell the anesthesia.
To prepare atropine standby and to prepare lidocaine standby with me.
Okay. Yes, because you might get bradycardia. Just tell the anesthesia. Because what happens if you don't tell him, the anesthesia will see bradycardia and he starts, why have bradycardia? He gives atropine, he starts thinking, But usually when I
Yes.
get closer, I tell the anesthesia, look, if you have any bradycardia, talk to me. Don't treat it because I can't treat it because I treat it from your side, not from his side. You just give some lidocaine, you inflate the cut body, and then you'll be fine. You don't need to give him atropine or anything else. This works better. So always when I get close to this area, I talk to anesthesia, tell them, look, I'm close to the cut body. If you have any bradycardia, let me know. Okay? This is an important step. Then you
Yes.
dissect internal, external carotid artery. Okay. And then you pay attention to what? To the which nerve?
Hypoglossal.
That's correct. Okay. And then after that, what you do?
I give heparin 100 international unit per kg
Okay.
and wait for ACT to be more than 250.
Okay. ACT.
Then I start by clamping the internal carotid artery, then common carotid, and finally external carotid.
Okay.
Then I do longitudinal arteriotomy at the common carotid artery and extend it to the internal carotid artery.
Okay.
Then I communicate with the neurologist and anesthesia for the neuromonitoring. If there is any abnormality, I will put my shunt.
Okay. Before you that, you forgot one step. Before you clamp, what you ask anesthesia to do?
Raise blood pressure to be more than
Yes.
140 to 160.
Correct. It's very important because we know that brain perfusion depends on your systemic pressure. So you need high blood pressure. So before we clamp, we ask anesthesia, please, I need a high pressure. And usually I stop. If the pressure is low, I wait. So don't rush. You at least I need the pressure at least 140, 150 to 160 before we clamp. Okay. You don't want like to clamp when pressure is 100, you know. So communication in this case with the procedure with anesthesiology is very important. Okay, so you raise blood pressure, you clamp as you said, you open, see like dumping in the waveform. So what you do?
I will put my shunt.
Okay, you said my shunt. Okay, what is your shunt? Is Dr. Bala shunt is a new shunt?
I will put tube shunt, Javid shunt.
Okay, Javid shunt. Okay. How you put the Javid shunt? Where you put first, antenna or the camera?
I will put in the internal first, wait for back bleeding, then I will put in the common.
Correct. Oh, and then what you do after that?
After that, I will recheck my neuromonitoring. Then I will do endarterectomy.
Okay.
Then I will prepare my batch and do batch closure.
Oh, just a second. Here is important. You forgot very important step. Because after that, you can tell you got your anastomosis, thrombosed. You know why? Because it was a big flap. So you have to look for it. So you have to tell him that. You see, anything you don't tell him, he thinks that you're not going to do it. So after you enterectomy, you have to tell him, I flush it, I look for any flap or any debris, you remove them, any flap, you tag it. So it's a very important step. Okay?
Yes.
So don't forget that. So after you take the plug, you say, I flush it with heparin. Then I look for any, debris, I remove it. I look for any flap, I tag it. Just be sure everything's fine. Then I put my patch. Okay?
Yes.
He may ask you what type of patch. I mean, you have an option, whatever you want. What type of patch you use?
Bovine pericardial patch.
Okay, it's okay. Any other patch you can use?
I can use BTF patch.
Okay, or
saphenous vein.
Yeah, someone has vein, so don't do that. Okay. So you do a patch, and after that, how you declamp?
I do a temporary internal carotid declamp to flush. Then I reclamp it again. Then I open the external, then the common carotid. I wait for 10 seconds. Then I open the internal carotid.
Okay. Don't forget to take a shunt out, of course, right?
Yeah, of course.
Okay. After you finish, what you do?
I do intraoperative ultrasound completion.
Okay. What are you looking
Then
for?
if there is any intimal flap, if there is any thrombosis, if there is any abnormality in the wave.
And velocity, of course, right?
And velocity, yes.
Okay. So everything looks fine. What do you do next?
I do hemostasis securing and I put drain and formal closure.
Okay. Okay, that's good. think that's enough. Let's see the next question. What's finding in the compression duplex would warrant you further investigation? So the duplex ultrasound, what make you have to do something if you find what?
If I find any flap in the internal carotid, if there is any internal thrombus, if there is any abnormal velocity.
Okay, then you have to interfere. Okay.
Yes.
He wake up and has a normal neural exam in the OR, but after an hour in the PICU, he developed dense right hemiplasia and slur of speech. This is very common scenario. It's very, very important. So we're going to discuss that. We can discuss two scenarios. This scenario, second scenario, if you develop after the procedure, you're still in the OR. So let's go with this scenario first. So patient wake up fine, went to the recovery. Then an hour after that, the nurse call you and said, doctor, he's not moving his whatever, right or left side. What's your next step?
I will.
It has to be in steps, because one is not what you do in general. Do this one first, second, third, fourth, because the consequence is very important.
Yes, I will do emergent CT brain.
No, before that.
I can do ultrasound duplex in the backhoe, but
I don't want to do I can. As I said, we prefer the exam. We don't use I can. So what you do? First thing, you call the OR, because you know OR, they need an hour to get ready. Okay, so you don't wait
yes,
until you make diagnosis, because it's easier to cancel than to book an OR. So when this happened, the first thing I'll call the OR and say, guys, please stand by. I may have to take a patient back. So they be prepared. You know, is the first thing, because now we're talking about timing is important. The timing is very important because patient is stroke. So timing is very important. So you call the OR, tell him be prepared. Then before rushing to the CAT scan, the first thing you want to know is that is your job or the intervention job. Did he embolize distally or did he thrombose your graft? Because it's different. If you thrombose your graft, then you have to take him back to the OR. If he's embolized, you can send him downstairs for whatever CT scan and embolectomy, you know? So you need to do that. And this has to be done quickly, because don't send him downstairs, CAT scan tell you thrombose, and then take him, because CAT scan takes a long time, then you know you lose time. So again, call the OR, then start the recovery at the bedside. If I see the bedside, the stent, my repair is normal, is open, then I have to find what's going on. Then I send him to CAT scan, because it could be two things. If the stent, your repair is normal, what other things can cause his stroke?
it can be something distally.
Embolization
Can be emboli, maybe intracranial hemorrhage.
or hemorrhage or stroke. So don't give heparin. Don't start, okay, let's go give heparin. Okay, don't be careful, because it could be bleeding. So what I put dissection, this time embolization or bleeding. So the reason why I need a head CT scan now. But if I find that my area with thrombose, my repair, I don't need a CAT scan, right? Well, going to get me help. I just rush him back to the OR.
Yes.
Correct?
معلش دكتور سامر if I do ultrasound in the backhoe in the recovery, sometimes it is very difficult to see because of gas and the drain. Sometimes very difficult to evaluate the internal carotid.
Then it's better take him back to the OR and open him up. You see, in the exam, see, forget about your real life. You know, in the exam, you have to be on safe side. In this situation, I'll take him back to the OR and open him up, because not big deal. It takes 5 minutes to open him up, open the graft. You do after you open it up, you do ultrasound after you open, so you can see it, or you open and you look inside. There's nothing, and you can do interruptive angiogram on the table to see any stabilization. If you see stabilization, then you close him downstairs for embolectomy. If there's nothing normal, then you just close and that's it, you know. But in this scenario, if you cannot see, if he tell you you cannot see much, you cannot see well, don't send him for CAT scan. No, I'll take him back to surgery. Because in the exam, you have to be on the safe side, okay? In real life, I may do differently. Yes, if the CAT scan is very quick, I may catch him CAT scan. But in the exam, please, guys, you have to be on safe side. You know, even if you tell him right, I take him right away without even ultrasound. They tell you ultrasound is not available. He may ask you this way: is the recovery and ultrasound is not? You don't have ultrasound in your hospital. What you do? Don't send him for CAT scan. Take him back. It's okay. It's better to open on negative than miss a stroke. So if he tell you, okay, you don't have ultrasound in your hospital, Then I'm okay. Then I feel more comfortable. Take him back. Let me open and be sure I didn't, there's no flap or whatever clot. If it's normal, I do interval angiogram, then close and send him for CAT scan. But don't send him for CAT scan before you're sure is your repair is fine. Because the first thing you have to blame is your repair.
Yes.
Especially it happens after an hour. Because if it's embolization, most probably it happened right after he wake up with a stroke, if he embolize, right? But because it happened after our recovery, so most probably some problem with your repair, either a flap or thrombosed or something happened in this area. Takes some time to develop. But if you wake up with a stroke, it's different. We're going to talk about different scenario. If you wake up with a stroke, what you do? But in this scenario, again, ultrasound or call OR, ultrasound. If it's negative, CT scan. Ultrasound positive, OR. No ultrasound, OR.
Okay.
All right. This shows a thrombose carotid bifurcation. What you going to do next?
I will
We
take
talk
him back
about
to
it.
OR. Yes, I will.
You describe your thrombectomy. You just reopen it up again, right? This is important. How you do thrombectomy?
Yeah, I will clamp common carotid and the external. I will not clamp the internal carotid.
Okay.
And I will let the
Wow.
back bleeding.
Okay. That's correct.
Yeah.
Go ahead.
Yeah. I will let the back bleeding come from the internal carotid.
Good. Good.
I will. Uh,
Can you do Fogarty?
I will not do Fogarty.
Yes, I mean, if you see good back bleeding, yes. But if you don't see back bleeding and it's like something distal, you can do it. But first, you have to be very, very gentle and you don't go too far. So what happened? You measure, you just go like 5 or 6 centimeters. That's maximum. So you measure you don't go like when we do Zalex, you go this until stop. No, you can just measure about 5 centimeters. Some people, they measure it to the base of the skull or the ear lobe, and then you do. So you can do it with a two French Fogarty, simple embolectomy. But if I see like fresh, clot came out and you have fresh back bleeding, I will not do the embolectomy because it's risky. But if I open and remove the clot, still I don't see back bleeding, then I'll try with the gentle embolectomy. But again, you measure before you go down, you measure about 4 or 5 centimeters. I try not to go beyond the skull base and just do simple embolectomy. Okay, and after that, you close your, where you open? You open your patch, right?
I will open.
The
I will
mid
open
part
my
of the
patch.
patch.
Yes.
Yeah, but don't remove the patch. No, we don't remove the patch. We cut the patch itself. We don't need
Yes.
to remove the whole patch and look, because why need that? Just cut in the middle. I do transfers or longitudinal, doesn't matter, because this is a fabric, so you can switch a longitudinal or transfer the same, doesn't make a difference, different from the artery. So you make small incision and then you do embolectomy. Okay, let's see what they said. The internal carotid back bleeding nicely. And there is a flap at the distal endpoint. What you do address this? How would you address that? So what happened after you did thrombectomy? So like a flap at the end, close to the proximal anastomosis, at the head of the anastomosis. So what you do?
I will
See a
do
flap.
posterior tacking of the flap,
Yes.
and I will close.
But he said, yes, but he said distal endpoint because he wants to tell you that it's really far. You see, he didn't tell you in the middle.
I need to
Extend your
redo
incision.
my batch.
I mean, it's okay, but what you do is that you just cut through the anastomosis, and most probably I will redo. I agree, because the moment you cut through the anastomosis, the whole batch is get loose, Then so you extend your arteriotomy until you see the batch the flap very well. Then you tack it, and then I just remove the patch and put a new patch. Or if you want, you can put. I think the best way to put a new patch, because it's very difficult to fix it. Doesn't work to put a small patch this area. So I agree with that. I'll just take the old patch and put a new patch. All right. Did very good. Thank you, Bara.
Thank you,
Any
Dr.
question
Khan.
about this case? Any question about this case before we go further?
مساء الخير دكتور سمير.
يا هلا، مساء الخيرات.
بالنسبة للسؤال 12 ده، مش ممكن أول باخد ممكن أعمل الباكينج سوتشر، ولا هو قصده لو كانت في البروكسيمال ممكن أعمل باكينج سوتشر، لكن لأنه هي ديستال فمش هتنفع.
Shri, suture, say that again. What kind of suture?
اللي هو الباكينج سوتشر.
What is bulking match? What is bulking sutures?
الباكينج
How
سوتشر
you
اللي هو
do that?
أجيب اللي هو البرولين 6-0 بالإبرتين، بدخل من جوه ومن إند أوت إن أوت بالإبرتين، بحيث إن أنا يعني
يعني you
ألزق
tag it.
الفلابة.
You tag it. Yes, you
يس.
tag it. Yes.
يعني can
Yes.
I
I
say
mean, if
that
you see it,
as an answer?
yes. Yes, it's a good answer if you see it. Unless if you tell you, okay, you cannot see, it's difficult. Yes, this is what I usually you tell her. When you say, I just go and tag it, with 6O protein. But if he tell you, no, it's too far, you cannot see it, then
هعمل إيه؟
extend the incision, extend it, extend. You already opened the patch, so extend your incision all the way to that. Like you go more distal on the internal carotid artery, so you open more distal, so you can see the flap, and then you tag it, and then
يعني
you
اللي
put a
أعمل
new
extend.
patch.
سوري، اكستند
Extend.
يعني الانستيشن على طول الانترنال كاروتيد.
Yes. Yes.
شكرا
So you
شكرا.
want to go a bit higher, but you have to have a good exposure. If you don't have exposure, it's a problem,
ايوه.
I mean, if I don't have, like they say, it's too high, I cannot even go any distal, I may just put a stent there. From the same incision, I just go there and put a small stent. If I can, let's say it's too high, let's say you can't reach it, or you already dissect too high and high bifurcation, and you cannot go further, and you see a flap there, then I just do an angiogram and I put a stent there. You see, in the oral, you have the luxury of discussing the case. It's not like black and white. But you don't go to jump to this one. Just go straight forward first. You say, I just go and tag it with a 6O proline and stop. If you said no, you cannot go distal, then you tell him. But don't volunteer from beginning to do like I go distal, I put a stent if I cannot see it. No. Answer exactly what's the question. You said you see a flap, then say I tag it. You said you cannot see it, you need to say I go further. If you said you cannot go further, then you tell him I stent. You see, but don't tell him all this information from the beginning because he may not need it. So like what Barat that was doing today was doing great. He was answering and stopped. Just exactly what the question he was answering. He stopped. He didn't give too much extra information. So in this exam, I just tell him I tag it as you said with 6O proline and stop, and then I close it. All right. Any other question?
Assalamu alaikum, Dr. Samer. Thanks for you.
Alaikum salam. Yeah, hala.
I want to ask about he was tell for this operation taking the patch from saphenous. Is that right, or from femoral vein, or no different?
No, we take it from saphenous femoral vein. We don't take a patch from the femoral vein, just only from saphenous vein. And always you can get a piece because you see, you just need a small piece, different from if you do femdistal bypass. With femdistal bypass, you need the whole vein be beautiful. But when you do a patch, any piece, small piece from the saphenous vein will be acceptable. I see people, they do that routinely. They use saphenous vein, but I see cases where the saphenous vein ruptures. So, or they get aneurysma dilatation. I don't think it's the best choice. Now, it's the best choice is to use, dacron patch or use bovine patch.
Okay.
But saphenous vein, unless you have an infection, then you use a saphenous vein. If you have an infection, if you tell you that you have to go there, you find infections, then I use saphenous vein.
Okay. But doctor, I was read before we can take this facial vein as a patch. Is that right?
And people write a lot of things. I don't think it's a good idea because it's very thin. You see, if you see the facial vein, it's very, very thin. Really, saphenous vein is thick. Like last time we had an injury where patient, he cut his posterior tibial artery and vein. So we need interposition graft, vein graft for posterior tibial artery was a trauma. And the posterior tibial vein is already cut. So I say I can use posterior, tibial vein. But when I took the vein, it's very
not tibial, it's facial vein. That was
I understand. I'm just giving an example. Is that any other veins are very thin. It's not good, so I do not use it. It's too thin.
okay.
So the same facial vein is very thin.
Okay.
So I mean, unless if you go, I mean, it's your decision. I mean, if you go there and find it's good for that, why not? Yes. But in general, when I see which I saw, most of the time I see it's very thin vein. Savannah's vein is bigger. But if you go for some reason and you find it, or maybe external jugular vein, you can try that. Whatever, you need a vein at the end, you know.
Okay.
So whatever is suitable, it's nothing like black and white. If you find it's a vein and you're happy with it, it's good, thick vein, nice vein, yeah, go and use it. I have no problem with
Okay, clear يا فندم.
that. Okay.
الفين وات ايفر اباف اور بلو يعني بالنسبه للسفنس صح ولا لازم اباف؟
It doesn't matter really. I mean, if you want to go above the ankle, you find like a small piece vein and take it, it's okay. But most people, they go to the groin. But you can, what I'm saying, you can do the ultrasound, right? Because you can go blind, you have the ultrasound. So whatever you find a piece, you'll be fine. But most people, they go to the groin. It takes the first part because it's a bigger vein and you know, it's bigger vein in the groin area. So most people go to the groin, but you can go any place. Just give me a vein. Doesn't matter really.
شكرا جدا.
Yeah.
طيب بص when we can we do primary suture without graft
Without patching.
without patching, yes.
Yes.
Is there
It's good. A lot of people, by the way, a lot of people, they do that, you know. It's
Okay.
not wrong.
not
All the
recommended?
study showed is no different between stroke rate between if you do primary closure or patch. The only thing
Okay.
they found that if you use the primary closure, the
Okay.
restenosis is much higher than if you use a patch.
Okay.
But most restenosis of the entire carotid artery are asymptomatic. Most
Okay.
of them, 99%. The reason why is no difference, you know. But you see more stenosis, but majority are asymptomatic because when you do restenosis, different from primary stenosis. Primary stenosis is a plaque which get, you know, embolized the brain. Whereas secondary stenosis after surgery, it is fibrosis, so it does not embolize. It
Okay.
just causes some turbulence, which can be treated with antiplatelets. You know, even when you do redo, there's no like if you do redo surgery. I don't know if they give you this question. When you open the artery for redo, there's no place for endarterectomy. You don't do endarterectomy. You just open and put a patch. The reason why
Okay.
the best treatment for redo is a stent,
Okay.
because the risk of embolization is very, very low because no plaque, you know. So when we used to do a redo in the carotid, we used to do just open the, you know, the area of stenosis. I would just put a patch because no plaque inside. You see just the artery nice and smooth. It's just fibrotic. It's just getting small. I mean, narrow. So, so no difference between both. But in general, if the artery is big, like 4 millimeter, or after
Okay.
you do endarterectomy and you see the artery become really big, you can do primary closures, no problem. But if the artery is small, especially female, always better to put a patch. I do patch all the time, but sometimes if the artery is too big or it's very good size, I just do primary closure.
You mean after do endarterectomy or this we can put display
Yes, then you
before
decide how is the artery. Yes, you can do primary. If you don't have a patch, it's okay. Primary closure is acceptable. Again, the incidence of stenosis is higher, but the incidence of stroke is the same. So it doesn't make a difference.
Okay, thanks, bro.
Or you do an evergent technique.
Okay.
Okay.
Yes. Yes. Clear.
You can don't in the exam don't describe evergent technique. You don't know how to do it. If you know how to do it and you want to use this technique, it's okay. But I don't prefer that because most doctors or examiners, you don't know evergent technique, so may not like it. So stuck to the conventional treatment, I think it's better. And again, in the exam, better to be like safe side, you use a patch, you know. In
Okay.
real life, you don't want to use a patch. I have no problem with that. As far as the artery is good, and the male, female always put a patch is better.
Okay.
Okay.
But sometimes there is
Any other-
indication of eversion technique.
Yes. But look, if you never did it, don't give this answer.
Okay.
If you never did eversion technique, like me, I never did eversion technique.
Okay.
No, I never did it. So I don't know how to do it. I do not. And so I do it for everyone. Yes, I know some cases are very good. Suppose they're very good with the version technique. But by the way, none of the studies showed this difference between inversion or standard. The reason why the society, they said recommendation, whatever you feel comfortable, you do it. It's not, none of them, they say this is better than this one. No study showed one is better than the other one. The only
Okay,
problem
clear.
is the inversion technique. If you want to put a shunt, will be very, very difficult. It's the only problem, you know, because you cut the artery, it's very hard. You can put a shunt, but it's very hard, very, you know, but they are depend on, they are too fast. That was they tell you. We don't need a shunt because they are too fast, because they just cut and suture.
Okay.
So again, I mean, if you're, you know, doctors, you know how to do it and he taught to you and you are comfortable with it, do it. If it's not, stay with the standard technique is better.
Thank you.
You're welcome.
Thank you, doctor. I'm on my MD exam these days, and I got a question about restenosis in CAA and carotid artery stenting causes and how to fix it. If you can please tell us more about it and
Okay.
all details, yeah.
Okay, no problem. But restenosis after cardiac or after stenting, correct? Hello?
Yes,
Can you hear
doctor.
me? Yeah.
Yes, doctor, in
Okay.
both techniques.
Okay. So if you had a cardiac and after like 7-8 years, patient come with restenosis, okay? If it's symptomatic or asymptomatic. If symptomatic and more than 50%, you do it like a normal one. If it's more than 50% and symptomatic, then the guidelines tell you to do a stent. Because if you do surgery again on him, there is a risk of nerve damage is higher than, you know, than stenting. So really the guideline tell you if patient had stenosis after carotid surgery, more than 50 to 90%. I mean, if it's symptomatic, 50 and above, you do him. Less than 50, medical management. This is for symptomatic. Asymptomatic, again, 70 and above, like 80 or 90, they recommend to do it. If it's less than that, then medical management. Okay? So now the question, should you do redo surgery or stent? They said the first line should be stent, not redo surgery. Unless you have contraindication or you don't have a stent, then you do redo surgery. If you do redo surgery, as I said, you just put a patch. You don't do endarterectomy. But you have to tell the patient is a higher incidence of cranial nerve injury during redo surgery. What else you have to know? This is for surgery. For a stent, if you get restenosis inside the stent, if it's symptomatic, then you can restent it again or reballoon it. If it's asymptomatic, then leave him alone, medical management. You know, because restenosis inside the stent for asymptomatic is very difficult to deal with it. So if patient asymptomatic, just medical management. But if it's symptomatic, then either restent it or you have to do a surgery. Take the stent out or patch it or whatever you have to do, you know, deal with it. Is this clear or answer a question or not?
Yes,
Or
thank
I
you,
got you
doctor.
confused.
No, I got it. No, it's okay.
So again,
I know the details.
Symptomatic. Yeah, and the only difference I tell you, symptomatic all need to be treated, you know.
Yes,
Stent or surgery, same thing, it has to be treated. But the only thing, the treatment should be endovascular, not open. Unless endovascular is not like he has like calcified, difficult arch, shaggy aorta, you cannot do TCAR procedure, then you do an open endarterectomy. For stenting, no, try to be conservative. With the stenting, even symptomatic one, try to be conservative, you know, with the stenting. Unless if symptomatic in the TIAs, then most probably you have to do a surgery or restenting, but most probably they prefer to people to go with surgery. Then you decide, you know, this is when you have MDT meeting and you discuss the neurology with the radiologist and you decide, but you have to interfere if it's symptomatic. If asymptomatic restenosis inside the stent, I'll leave him alone, medical management.
Thanks, doctor. It was a written question, so I talked also about intimal hyperplasia and the causes of stenosis, restenosis in the first 6 months and after that and later. So I had a lot of details to tell. Thanks, doctor.
Yes, I mean, first, after many years, they may get an atheroma inside the so you may get redo atheroma. But if you get it soon, most of it, I think, is fibrosis. All right, any other question? Okay, let's go to the next scenario, maybe find something different. Who want to take the next one? 25
Yes,
years old. Go ahead, please.
Bismillah. This is a 75 years old woman who is an active smoker presented to emergency department with a left facial drop that resolved shortly after arrival. She has no significant past medical history other than distant MI. Physical examination is unremarkable other than some mild slurred of speech. ECG show she is in a sinus rate.
Okay, so active smoker. She came with the TIAs. Very remarkable other than some mild slurred of her speech. EKG shows sinus, so it's not an arrhythmia. Okay, so the question, what do you do next? So you're in the ER and they call you for this kind of patient. What do you do next?
Okay, I will take a more detailed history focusing on her symptoms, if it has previous past history. And we'll do quick examination focusing on the neurological examination.
All right. What are you going to order? Any testing?
We'll order duplex ultrasound and CT brain.
CT brain, correct. Okay. So when ultrasound reveals 70% stenosis of the right internal carotid artery, CT's head is normal with no finding of acute stroke, right? So we're going to do next. So she has 70% stenosis, right? CT is negative for stroke. What are you going to do?
Okay, I will do a CT angio to see to confirm the degree of the stenosis and to see the.
No, we did that, right? Duplex. Sorry. Yeah, you did only have a duplex. Okay. You did CT angiogram to see the stenosis. Okay. And what else?
Circle of Willis.
Okay. What else? What you have to order is something very important. You order CT with the neck to write something because some technicians, they don't do that. What is that?
The cut slides.
Yeah, you have to tell them to start from the arch because some people, they start from the neck, supraclavicular. So you miss the arch. You need to see the arch just in case you have to do stenting. So very important when you order CT of the neck, CT angiogram, always write a note to the technician, please show me the arch. Because many times I see them, they just start supraclavicular and you don't see they cut the arch, So it's very important to tell him that. So you're going to look at the arch and you're going to look for degree of stenosis. Correct. How long would you wait prior to CA and is there any test you would do prior? So you decide to do a surgery on her. When surgery should be done? What the guideline tell us? When patient come with the symptoms, when the best time to do the surgery?
Best time to do the surgery after 2 days and before 2 weeks.
This is correct. This is the best time because after that, really, you lose the benefit. And this is very important. When patient comes symptoms should be within 2 weeks, it has to be done a surgery. If patient came with he came to your clinic, 20% stenosis, and he said, I have a TIA about 7 months ago. Okay. Is this symptomatic or asymptomatic?
6 months is asymptomatic. Beyond the...
No. He came 30% stenosis. Did you tell him, did you have any TIAs? He said, yes, I have TIA 7 months ago. So when you look at this stenosis, are you going to consider it as symptomatic or asymptomatic?
asymptomatic.
Why? He said he has a TIA.
Yeah, it's just the symptoms. It will be up to the 6 months.
And after that, you're correct. Your answer is correct. Any symptoms happen after
Are
7
considered
months, we consider
asymptomatic.
asymptomatic. Correct. So it's very important. So I cannot tell you like last year have a TIAs and you consider it symptomatic. So anything TIA after 7 months, then we consider this stenosis asymptomatic and we treat it as asymptomatic. If you had TIAs within 6 months, then we look at this stenosis as symptomatic because treatment is different. Okay. So let's go to the next question. Review a CT scan showed a focal bifurcation lesion with an intact circle of Willis. Describe your operation. We went through that. We don't have to go through again. Again, I'm going to ask you about the shunt. He's going to ask you about, the patch, how you measure the brain, the same thing we went through. So let's skip it. How do you determine, what do you use? Let me ask you. Are you in practice, Dr. Mustafa? What do you use for monitoring? Or you doing the local? Hello?
Yes.
Yes. What do you use for monitor the brain during surgery? I think connection is bad. Hello?
Yes, boss. Sorry.
Connection is bad, huh?
Yes, doctor. I'm hearing you now. Yeah. Sorry. Is it okay now, boss?
Yeah, it's better now. Yeah, please. No, we keep losing you. Does anyone want to pick up the question and continue? Also, we had some problem with the connections.
Yeah. Describe the operation now. Describe the operation, boss. What the?
No. We don't need to describe. No, we did that.
Okay.
No, we don't need that. Let's go to the next question. How do you determine when to shunt based on the stump pressure? We talked about it before. She's near intact in vacuum, but her blood pressure remained very high. What would you like to do? Okay.
Okay. Yes, boss. High blood pressure recovery. Most likely, she start to develop hyperperfusion syndrome.
So what do you do?
Cerebral hypertension.
What would you do?
We'll shift the patient to the ICU to control her blood pressure. We'll start
what pressure you want to maintain? What pressure you want to keep it? What the parameter you give it to the, to the nurse? What pressure are you looking for?
120 over 80.
So 130 is not acceptable. What is it? 130, 140? So let's 160. Okay. So they tell her the highest. You give her, I don't want to do more than 160. Okay. Because high pressure, you can bring it to low also because she used to high blood pressure. So if you go to 110, 120, I think it's a bit low side. Tell her I need it to be less than 160. But mostly we need like around 130 maybe, But you need high pressure because low pressure is not good also. So you have to be careful. You don't want her to become hypotensive like 80, 90, then she can go to stroke. All right. She recovered well and she discharged home, but she called clinic 3 days saying that she has a headache. Same side she has CA. So what do you tell her? Take an aspirin, take Advil. What do you advise her?
We'll ask her to come back to the hospital.
What you are concerned about?
hemorrhage
Or
or
you just tell me about it, Reber-Feijden syndrome, right? Hyperperfusion syndrome, right? Because why? Because she's hypertensive. She has endarterectomy, you see. She has bilateral carotid stenosis. All this put you, and she has high-grade stenosis. When you have high-grade stenosis and you open the artery, then you get
risk
more
factor.
perfusion to the brain, risk factors. So on the high-grade carotid stenosis, bilateral carotid stenosis, hypertension, surgery, all this put you on high risk of reperfusion injury. So you have to be careful. So a headache is a bad sign after cardiac endarterectomy, guys, please. So if the nurse call you, patient has a headache, don't tell her just give her pain medication and wait. You have to do a CT, you know. So this is what we have to do next. So you ask her to come, and then
Do the CT and
yeah,
the
her
blood
blood pressure
pressure.
160. Okay, did wide Duplex ultrasound, no CT scan, some edema with no hemorrhage. So what you do? Then you put her on. You bring her pressure down, put her on ICU, right? Okay. So this is should be normal. What your risk for this condition? We talk about it. What is that? What are clinical consequences of cerebral hyperperfusion syndrome? What could happen if you don't treat him?
Get the brain herniation or this.
Yes, a patient may die from that. So it's a serious issue. So again, headache after cardiac endarterectomy, always take it seriously. Don't say, oh, it's just a headache. Okay, very good. Any question about this scenario? So you can move quick.
Yes, boss. We can
Yes.
give her mannitol.
Mannitol?
Yeah, for the brain edema.
Yeah. Or hydrocortisone, you mean? I don't know. You have to consult. I mean, in this situation, you see, even the exam, don't act like you know everything, you know. The best way I call neurology also for evaluation, neurology consultations, you know, and let them deal with that. But for you, the most important to bring the blood pressure. In the exam, he just want to know if you are, you know what's going on with this patient. Don't tell her to take pain medication. That's all. And that you need to bring blood pressure. But how you treat brain edema, it's not going to ask you about that. It's not our specialty anyway. So don't worry about it.
Okay. Another question, boss. 70% in one side and 40% in the other side.
Correct.
The question like that, you will do shunting or not, and why?
Should nothing to do with the stenosis. By the way, the study showed if you have contralateral occlusions and you do like you do the right occlusion, you do the left, sometimes you don't need a shunt, even with the contralateral occlusions, because you can get from the vertebra. So really, it's nothing in the, unless if you go circle of Willis and you look for it, then you know. But in general, even if you circle of Willis is normal and you see back bleeding, or low bleeding, you have to shunt. So really, you cannot depend on this one to decide shunt or not, what degree of stenosis on the other side. And again, the study showed even if you have occlusion contralateral side, it doesn't mean you have to shunt every time. And I saw cases where contralateral occlusion, and I opened the contralateral side to fix it, and the back bleeding was excellent, so I didn't use a shunt. And the study confirmed that. So we have a study paper which confirmed that contralateral occlusion doesn't mean you have to use a shunt. You just go with same what we do, pressure, EEG, transcutaneous PO2. You go the same like if it's other side is not there.
Okay.
Any other question?
Thank you, boss.
Okay. I mean, couple of question you can. Yeah, go ahead.
السلام عليكم دكتور سامر، كيف حالك؟ عساك طيب.
سلام. يا هلا.
الله يحفظك ويطول لي في عمرك. It's just small question regarding the headache. The pain sometimes is subjective, depend on from patient to patient. If the patient have headache, but he said that it's controlled by regular analgesia, should I still concerning this is a fair point that the patient must get back to the hospital and check for himself, or just he can proceed with this analgesia?
Okay. First, if you're in the exam, you have to bring him back in the exam. Okay.
Yes.
Because again, when he tells you this in exam, he's not telling you you're going to give aspirin. He knows that when he tell you that in the exam he has a headache, he wants you to know that, talk about hyperperfusion syndrome.
Sure.
So he wanted to bring patient down this in the exam. In real life, don't take a chance. If she told me headaches, I will bring her, because better to bring her here with the negative things than you tell her she is fine and the next thing, because I said consequences could be very bad. You can get with herniation. So we don't play with the brain. So even for me, just to be, because you'll be liable if she died, if she has a problem of stroke, then you'll be liable for that. So why you took a chance? So if patient, she called me. If she didn't call me, it's up to her. She didn't call me and take blood pressure. But as far as she called me, that means it's really bad headache. Because the patient will not call you for headache unless it's really very bad. So as far as she called me, that means it's serious. But the problem, if the nurse call you, like in the middle of the night, you do come and talk to me, and the nurse, middle of the night, 2 a.m. morning, the nurse call you, say, doctor, she has a headache. Can I give her, headache medications? Then I think the best way is in real life to go and evaluate the patient, talk to her, see if any symptoms of hyperfusion, how is the headache? Did she have headache before? It's the first time? Is it on the side of the surgery, on both sides? Then you may slow down, not getting CAT scan. And then you monitor her slowly. But don't answer if she nurse call you in the middle of the night with a headache after surgery. At least if you don't want to order CAT scan, go and evaluate the patient. But don't give give a medication without seeing the patient. Be my advice.
Fair enough.
Okay.
Yes, possible. One more question.
Yes.
Regarding this patient with the cerebral hyperperfusion syndrome, any time limit? Because in this case, I didn't guess that she will come after 3 days with the cerebral hyperperfusion syndrome. That's why I'm thinking about the hemorrhage. Any time limit for the cerebral hyperperfusion syndrome?
No, not really, but usually happen. This is the average between 2 to 3, 4 days. I never saw it was after like a week, and really you see it right after that. Like it was in 24 hours. So I said like 48 hours to 3 days is the time where you get hyperperfusion syndrome. But patient has to be hypertensive. I never see it in non-patient with normal blood pressures. So this patient usually have uncontrolled hypertension. This is the time you see it.
Okay,
All
thank
right.
you.
Let me talk about something that's important. Sometimes out of guys you being called for clearance. Patient want to go for hernia surgery, and he has 70% carotid stenosis. So they want your clearance. Should you clear him or not? Anybody knows? Should we clear him or not? For non-cardiac surgery. I don't think you'll be in the exam you'll be asked this question, because in the exam also they give you a scenario like this one. But I think it's good for your life practice to know these things. So if you have they did an ultrasound for some reason, and patient is asymptomatics, and he has 80% stenosis, and they want to do surgery.
Sir, I don't know, but I have never read about these things, but I think logically, the patient in anesthesia, he may develop hypotension. So with this high-grade stenosis, he may develop stroke. So I think need to be interfered before doing any procedure in the hernia.
So, okay, let's talk about it, because guys, it's important to write it down. What I'm talking about, all guideline. It's not like my protocol is a guideline. So non-cardiac surgery.
If the patient have Berui, this need for following. Or
is that again? If it's what? The patient has Berui?
Berui, carotid Berui, this patient need for follow for carotid.
Okay. I'm saying no. I'm saying this patient already had a carotid ultrasound and showed he has 80% stenosis, and he's asymptomatic, and he want to go for hernia surgery. And this is very common. They call you and said, "Can we take him? Do you need the carotid first, or you have you have to do surgery first?" Asymptomatic patient with 50 to 99% stenosis, asymptomatic for non-cardiac surgery, no need for cardiac endarterectomy before cardiac surgery. So they can proceed, okay? So no need for, you can give him clearance, it's okay, because this will not increase your incidence of stroke. This is for asymptomatic. For symptomatic, again, 50 to 99% symptomatic, then you have to fix it before non-cardiac surgery. If it's less than 50%, then medical management. Then you want to wait at least delay the surgery for 6 months. So the patient less than 50% and he's symptomatic and does need intervention because less than 50%, like 40%, and he's symptomatic to get TIAs and he has to go for hernia surgery, then you tell them, no, we need to wait at least he has to be asymptomatic for 6 months. So he has to have free of TIAs for 6 months. After 6 months, no more TIA, then they can proceed with the surgery. Okay, is it clear?
Sorry, sir. Can you repeat it again?
Okay. For asymptomatic, talk about non-cardiac surgery. We can talk about cardiac later on. Non-cardiac surgery. Patient asymptomatic. Asymptomatic. 70 to 99% asymptomatic. Going for non-cardiac surgery, no need for intervention from our side. They can proceed with surgery without increased risk of stroke. Very clear. If he's symptomatic, then we look how much the degree of stenosis. Degree of stenosis is 50 and above, then we have to do endarterectomy before his non-cardiac surgery. If his stenosis is less than 50%, then we're not doing surgery because even symptomatic less than 50%, we don't do surgery usually. So we can treat him medically. But they have to stop, even treat him medically. You can't give him asthma and Plavix and tell them to go and do a surgery like next week. No, they have to wait for 6 months from his symptoms. So if patient getting TI, he had a TIAs last week, and ultrasound revealed 50% stenosis or less, then I'm going to put on asthma and Plavix for 6 months. And after 6 months, they can do the hernia surgery. So they have to wait for 6 months before they do non-cardiac surgery if you're not planning to do endarterectomy because stenosis is less than 50%. Is it clear or I confuse you guys?
Yes, sir, it's clear. But
So anyway,
Yeah,
asymptomatic, leave him alone. Symptomatic, 50 and above surgery, 50 and below, medical management, but wait for 6 months before you do surgery. Postpone the surgery for 6 months. Make it easier. Simple like that.
what if within the 6 months he develop another TIA?
Then you have to wait another 6 months. He has to be free for 6 months, okay? From the symptoms.
Thank you.
Okay, let's go to cardiac surgery. It's a cardiac surgery. This is the most common. Cardiac surgery. First question they'll ask you, do we need to do cardiac ultrasound for all patients before CABG surgery? The answer is no. Unless the patient high risk for cardiac stenosis, like he's a smoker, more than 70 years old, history of TIAs long time ago, any risk factor, then you look, but don't do ultrasound for every patient before CABG. It's not recommended. The first thing. The second thing, should we treat him or not before heart surgery? Again, symptomatic or asymptomatic. Symptomatics, more than 50%, then yes, we have to treat him before carotid surgery. Symptomatics. If it's less than 50%, just medical management, and then they can proceed with the heart surgery. If it's asymptomatic, this is the difficult part. If asymptomatics, if it's one side asymptomatics, then we don't fix it. They can go with a heart surgery. If it's on both sides and both sides significant, more than 70 in both sides, then we have to do one of them before surgery. And most of we do the one which is the dominant brain, which is the left side. And this is left-handed, then we do the right side. Or if he has contralateral occlusion, if one side is occluded and the second side is 70 and above, then we have to do it. Or he has bilateral severe stenosis more 70%, then we do them. But just one side, 70% and above, or 80%, and the other side is wide open, there's no need for endarterectomy before heart surgery. We can clear him. And this is very common. You can get that a lot in your practice, okay? So you can give him a clearance. The second question, should do a surgery or stent? It depends. Stent is better because this patient is a coronary patient. He needs a heart surgery, so most of he has a bad heart. So stent will be better. But the problem with the stent is that he has to be an anticoagulant dual at least for 3 months. So then he can be on single. So if the cabbage can be wait for 3 months and more, then I prefer do a stent. Then you put him dual antiplatelet. After 3 months, you stop the blood vessel, put him aspirin only, and then they can do the heart surgery. If the heart surgery is emergency or urgent, they cannot wait for 3 months, then you have to do a surgery. Then the question, surgery should be done with the heart surgery, before or after heart surgery. Is it controversial? The best way is to do it concomitant, the same time with the heart surgery, but nobody showed this which way. Some people do it before, some people do with, some people after. The best way, if you can do it before surgery and the local anesthesia. Because anesthesia is too risky for this patient because he has a heart condition. So in this scenario, the best way is to do cardiac endarterectomy before heart surgery using local anesthesia. I mean, regional anesthesia. This is the best scenario. Or if it's not, most people, they prefer to do carotid first, then the cabbage. If you can do them both, will be even better. Rarely people, they do it after. So most people do it either before or concomitant with the heart surgery. I think this is the old scenario about cardiac and carotid, or non-cardiac surgery and carotid. Any questions?
معلش دكتور سامر before يعني in the same day ولا before 1 day before ولا
I tell you, I usually, if I do a surgery, I do just a day before or 2 days. I tell you why, because I want to leave a drain. Don't remove the drain because they can't hypernize the patient. So you might get hematoma. So usually I do it a day before and then I leave a drain. And then after they finish the heart surgery, I did the drain out. It's very important to leave, put a drain and leave it there because they give high dose of, anticoagulation may end with a hematoma. So just be sure you leave a good drain. So 1 or 2 days, but not like a week or 2 weeks. I just do a day or two before. But the best way to under regional anesthesia, I think. Any other question? All right. What other scenario you can guys think about it? Common carotid artery. How we can fix it? Anybody knows common carotid artery? Should we do 50, 70, 80, symptomatic, asymptomatics? Symptomatic common carotid artery, everyone agrees that you need to do it. Surgery or stent, it depends. If it's very low, most of it stent. It is very high, or it has a radiation. Most of it, common carotid artery stents come from radiation. So most of it here end with the stenting, really. Common carotid artery, I think most of the time stent the best options. If patient asymptomatic common carotid artery, even 90%, there's no indication to do a surgery, to just medical management. The reason why, because internal we're getting blood from the external, so brain will be well perfused. So as a guideline, asymptomatic in common carotid artery is medical management. What else? Vertebral artery, asymptomatic vertebral artery, also leave him alone, even if it's like 80, 90%, we don't interfere. If symptomatic, then the best treatment is stent for vertebral artery. And most people, they like to use a drug-eluting stent for vertebral artery stenosis. What else? Kink is the internal carotid artery if you have any kink. Or a web. If you're asymptomatic, you leave him alone. If symptomatics, you need to do a surgery, but you have to be very careful. You have to talk to neurologists, do a lot of workup to be sure the symptom from there, because most of the time symptoms not from there. But if you did all the workup and everything's negative and the only thing to blame for his symptoms is the kink, then you may do a surgery. But again, after MDT meeting with a neurology, with a cardiologist, everyone agree that this is the source of his symptoms. If it's asymptomatic kink, leave him alone. What else we have? I think that's all. Most scenario in the carotid. Any questions?
Yes, boss. Regarding the stent, drug-eluting.
والويب بنعمل ايفيرجن تكنيك.
Let's one by one. Let's go about the web. What's the story about the web? What's the question?
مع الويب والكينك والالونجيشن في الانترنال كاروتيد ارتري بنعمل الايفيرجن تكنيك.
First, again, they have to be symptomatic. Let's agree on that. They have to be symptomatics, you know. For the web, you just open, they cut the web. We have 3 cases so far. I never did anyone for web, but my partners, they told me they did 3 cases of web. I think they're going to publish it. I never saw a web, but we just open, you cut the web, that's all. Because no endotracheal, nothing, I just close it. I don't think inversion technique will work because no plaque to remove it. For elongation, I did a couple of elongation or kink, but this is with carving in the atherectomy. Our patient has stenosis and elongation. So usually I do them both together at the same time. You just shorten the common carotid. I mean, inversion technique is a good idea to do it because this way you can shorten it and do it. But even with the standard technique, you can do it, but have a special way. You have to cut it like a V shape in both sides and you re-switcher it. It's a simple technique, but you can do it even with the standard. But most people, they like to do, you know, inversion technique for the elongation or kink. Okay, another question? Yeah, Hala. All right, maybe we just take one more case, then we're done. What time is now? Let's do this one very quick. This with the 3 cases. Somebody want to take it? Faisal, want to take it, Faisal?
Sure, sir. No problem.
Maybe I already answered this. Most probably, let me see here. Okay, let's go.
Okay. 76-year-old man presented to the emergency department with complaint of left arm, left and leg weakness and right facial drop. He is an active smoker, neurological evaluated the patient and had right neck bruit. And they are requesting a vascular surgery consult. He takes a daily aspirin and high dose statin.
Okay. So his came was it's like a stroke.
Yeah, stroke,
yeah,
sir.
stroke. Okay, that's good. We didn't talk about stroke. That's good. I forgot to talk about stroke. We can talk about stroke. Okay, so question, what do you do next as usual? How would you proceed? How can proceed?
Yeah, I will start with taking a detailed history and physical examination and risk factors.
Okay, that's enough. All right, so it has been 2 hours since he presented and his symptoms have been resolved. You notice that he has happening a few times over the last months. Your exam is back to baseline. Okay. So it's been only for 2 hours. She has TIAs.
Yes.
So what do you do next?
I will start to investigate my patient by doing full labs and image for him, ultrasound
What image you order?
ultrasound duplex and CT head and CT neck and brain.
Okay. He said his TI has been increasing. So what we call this one? Increase frequently and the time frame between them is decreasing. So what we call this one?
It's crescendo.
Crescendo TIs. So crescendo TIs, you have to be aggressive, you know?
Yes, sir.
Yeah, this one. You know what the best time to do crescendo TI is?
Early morning, next day, early morning, I think.
Yeah, it's like 24 to 48 hours. So should be like, yeah, next day, not middle of the night, of course. But
Yes,
majority within 24 to 48 hours, a day or 2 maximum. Unless you have to do some like cardiac workup for him, you can wait. But the sooner is better. But I'll do it within 24 to 48 hours, you know. All right. So CT scan negative for acute stroke, showed high-grade stenosis, EKG normal. What do you do next? Talk about surgery, right?
Yes, sir.
What time frame would you plan? We talk about it. Scapular surgery, we don't have to go through that again. Here we are. This is important. He wake up and he's not moving his left side. So now, this is a question also you may get in the exam, like a stroke right after we talk about the stroke and the recovery. Now we're stroke in the OR. He's on the table and he's not moving his left side. You wake up, he's not moving. What do you do next?
I will do intraside duplex ultrasound
Okay.
and check for
If the
my.
duplex is not available, what are you looking for?
I will re-explore my
No, you do
surgery.
duplex. What are you looking for in duplex ultrasound?
Yeah, and in duplex ultrasound, I will look for the velocity. I will see if there is any flap or thrombus at the side of the batch.
Okay, he tell you that you put the stables and out of stables there, and you cannot see very well. What do you do next?
I will open my patch
Yes,
and
so
check.
you explore the patient.
Yes,
right?
sir. Yes, sir.
So in patient on the table, again, you do ultrasound. The ultrasound is not available. They have to take him it takes them an hour to get it or too far. Then I will not wait. I just explore the neck, okay? Because you still know, you know. So you have to be very aggressive here. If the ultrasound is, available, it's like 2-3 minutes, no problem. If you're going to wait like 15 minutes or 10 minutes to get it, I will not wait for it. Just open the patient, okay? And then look that. Then you open the patch, and the same thing. You look for the patch. If then you have ultrasound, you look for the ultrasound. If there's no ultrasound, you open the patch. They look inside of any clot or not. If it's no clot, you do angiogram, and then you look for any embolization, something like that. Okay.
Yes.
This is what in the exam. In real life, I usually do an ultrasound. If the ultrasound is negative, I do an angiogram on the table right away because I'm already there looking for any clot distally. All right. The repair thrombose, what do you do plan now? We talked about it before. Same kind of fresh clot, how you do proceed, remove the clot, flap, we talk about it. Choose the current anatomy, you cannot patch it, you can reach it. This is what somebody asked me before. They can tell you this scenario, you cannot reach the dissection, it's distal. Then you just extend your incision, correct?
Yeah,
And
yeah,
try
sure.
to find, and then, yeah. No change in energy monitor indicates the need for shunt. The repair was successful. Patient wake up with energy deficit. What do you think was the cause of the distal dissection? I don't know, because somebody
This
did a good
best.
job.
Yeah.
So I don't know. It's the only thing I can't think about. You didn't dissect it right. You didn't dissect it well. I don't know. Something. How could this be prevented? You're doing a good job. Well, let's talk about acute stroke. Anyway, it's not at least not a good scenario. So acute stroke. This patient comes acute stroke. Okay, because this one was TIA. Let's say acute stroke. How we deal with that? You're in the emergency room, they call you, and patient comes with a stroke. It's about 4 hours ago. So what do you do?
First of all, make sure the patient age and his past medical history of diabetes and
Okay.
Full risk factor of patient history, physical examination.
Okay, next. Yeah, let's go to the step. What do you do? Yeah, okay, next. After examining him, what are you going to order for him?
This patient, if he's had stroke within the window, we can start for him TBA.
Before TBA, what are you going to do? Order what? Head CT, right? Because till now we don't know. Could be hemorrhagical stroke, right?
Yes.
Okay, so the first thing we ask for CT before we even touch the patient, was head CT. And then, because we have one case where the patient unfortunately died. I think he's died eventually. It's happened last week or 2 weeks ago. Patient came with a huge stroke, and then did a CAT scan, CT angiogram showed showed like hemorrhage to the brain. No hemorrhage, So we said we took him to the cath lab for mechanical thrombectomy by neurointervention, but for some reason the emergency doctor decided to give him TBA, peripheral TBA. The problem when you look at the CAT scan, he has a huge clot in the osh, huge clot, and he didn't look at the CAT scan very well. So when he gave a TBA, so anyway, so when patient went for, CAT scan showed complete occlusion of the common carotid artery. So yeah, so it showed complete occlusion of the common carotid artery. And patient has a stroke. So he just gave him TBA peripheral, but he didn't notice that the big clot in the arch. So what happened after he gave a TBA, the clot, break and went to the other common carotid and closed it. And then he become really brain dead and gone. So my idea is that before I give peripheral TBA, you have to be sure it's not clot in the heart or in the arch. So don't rush to give TBA peripheral because TBA peripheral doesn't work very well anyway. So again, patient comes with acute stroke. The first thing I will just get head CT scan. If it's a head CT, of course, you get a history. Be sure it's AFib or from a carotid. If he has history of atrial fibrillation, you think concentrate more on the heart. If it's not, you concentrate more on the carotid. But anyway, so you get head CT. If there's no bleeding, then he go right away to the cath lab for angiogram and possible mechanical embolectomy. But don't give TBA. If you decide to give TBA, like you don't have a neuro intervention, you want to give TBA, just be sure you do echo to the heart and CAT scan to involve the arch, be sure it's no clot in the heart. Because if you have a clot in the heart, you give TBA, you can break it and cause more embolization. So before TBA is very risky, you have to be very careful. Okay, so the question comes always is that you do neuro intervention successful, you remove the clot. The question, and you did ultrasound, showed he has 80% stenosis on the right side where he had a stroke. So when you do endarterectomy, and this is very common question. This is very, even real life, you can call you, the neurologist, that we did embolectomy, patient is recovering from stroke. What's the best time to do endarterectomy?
Well,
anybody knows?
We said it's 2 days to 14 days, but as the patient had been received TBA.
Can you please
Faisal,
repeat the question, please? Dr. Samer, can you please repeat the question?
Patient gives acute stroke, okay? And he underwent mechanical thrombectomy, okay? And now he's recovering from his stroke, okay? He didn't recover completely, he's recovering, but he just had a stroke and you underwent successful mechanical thrombectomy. And they call you now, and the ultrasound showed 80% stenosis of the carotid. So the question for you guys, what the time you going to tell the neurology I'm going to do fix his carotid? You fix it next day, after a week, after 2 weeks, after
till the
after
patient
7
days. Get his full recovery from the stroke. So we need to assist him from this.
Okay. Any other answers? What the guideline? I'm going to speak about the guideline.
Guideline said that after 7 days.
Okay. I don't think it's what the guideline said, but okay. Any other answers?
2 weeks.
It depends. The old teaching, they used to wait like for 2 weeks, Now we don't do that. They look at the 3 things. How much the brain damage, less than the third damage. If the neurological exam, what you call the score,
Franklin score.
Franklin score less than 3. More than 3 is bad. Like 0 or then less than 3. Then so less than third is more important. The brain should be less than third damage. It's more than third, it's too much. You can't convert it because the idea is that you don't want to convert it to a hemorrhagical stroke. This is what the neurology always tell us. I have always to fight with because I need to take patient to surgery. Like next day he's doing fine. I want to take him to surgery. I said no, you can convert it to neurological stroke. You want to wait 2 weeks. But we know that if you wait 2 weeks, usually endarterectomy should be done within 2 weeks. If you wait more than 2 weeks, you lose the benefit, of the current endarterectomy. So usually it should be done really between 2 days to 14 days. But to do it, you have to have this criteria. First, the damage to the brain should be less than the third. So the half of the brain that damage on the MRI, of course, you can see the MRI. The MRI, you see that stroke less than the third in its indications. And if the score is less than 3, then you do it. If it's more than 3 or more than a third of the brain is damaged, then don't do it because you can convert it to the hemorrhagical stroke. Okay. So usually I look at the MRI, I talk to neurology. If patient is waking up, he's talking to me, he's doing fine, he's very mild residual stenosis. I did MRI, it's just mild stroke. Then I do surgery like next day or day after. Is this clear?
Yes, very clear.
Okay, it's very important in your real life, you know. Good to see a lot of patients like that. They come with a stroke, severe stenosis, and the question, when should I do it, you know? So have this guideline, because the neurology may argue with you, say, no, we want to wait, you know, 2 weeks before you take him to surgery. Discuss with them and show them the guideline. And it's very clear that this is a guideline saying you have to do it less than 2 weeks if this so and so is applicable. I think we have enough today. Also, we have a headache by now, guys. Any questions? Maybe we'll do more scenario next week. We do more cases. Yeah, any
I'm
questions?
sorry, doctor. If patient came with TIA, should we do it from 2 to 14 days or more urgent than that?
No, within 14 days is better. No, not more urgent. It's a TIAs, you know. TIAs is no urgency, unless it's a crescendo, it's different. If it's crescendo TIAs, you have to do it within 1 or 2 days. Normal TIAs, patient come with weakness, 2 hours, he recover back to normal, no, it's no rush. Unless he tell you I'm having like more frequent, as we saw from scenario before, then you have to do within 24 to 48 hours. But if it's not crescendo, just TIAs, then 2 days to 14 days is the best time to do that, to get the benefit, you know. But don't go and schedule him after 3 weeks or 4 weeks, you lose the benefit. So patient comes to the clinic with the TIAs or to the ER, just book him for like after a week or 10 days, but within 2 weeks, please. Yeah. Any other question? All right,
Thank you.
guys. Thank you very much. Thank you very much. We'll see you next week, hopefully.
Thank you.
شكرا دكتور
Thanks.
سامر.
Bye.
شكرا جدا.
Take care. Bye.
السلام عليكم.
Salam.